Well, hello and welcome, everyone. Thank you so much for being here with us today as we gather in observance of National Minority Health Month for our special panel discussion featuring sickle cell disease trailblazers and individuals living with sickle cell disease. Today's conversation promises a diverse range of perspectives from historical insights to contemporary experiences, focusing on sickle cell disease care across the lifespan. We will also take a moment to honor early milestones in sickle cell disease research and care. To start things off, I am so pleased to introduce Secretary Javier Becerra, who is the 25th Secretary of the Department of Health and Human Services and the first Latino to hold the office in the history of the United States. Secretary Becerra, please begin.
Admiral Levine, first to you and to everyone who is joining this call, who has worked on this issue of sickle cell disease for quite some time. I just want to extend my thanks for making this a priority. I have had, I think, Admiral, since you and I were sworn in at HHS some 3 years ago, we have had this as a priority to tackle. As I said to many of you back then, this is something that we should close the books on. We should be able to resolve issues of sickle cell disease for the more than 100,000 Americans who suffer from this disease and have suffered in great pain, and oftentimes in silence and without the help that they need. This is one where we can make a difference. And I don't know if you would all agree with me that perhaps we're at this point where we've turned the corner on sickle cell disease. But we are certainly in a different place today than we were 3 years ago when we were talking about how we could tackle sickle cell disease for those Americans who really have been looking for their country to find them a better way. And I must tell you that the discoveries of these cell therapies that can help some people not only live a much better life, but perhaps even be cured of sickle cell, now that those are before us, I think many of us believe that we really are at this point. If we haven't yet turned the corner, we can see the corner on the horizon. And that is good news. And at HHS, that means for us, we're going to work doubly hard to make sure we get to the corner and turn it. And that's why it is so important that under President Biden's leadership, we are now at a point where we can offer to Americans with sickle cell disease access to the therapy that might be life-curing. And through the sickle cell, the focus first and foremost in gene therapy on launching through CMS, our project that would let us provide the treatment to those Americans suffering from sickle cell disease in ways that might not otherwise be achievable, attainable, affordable, that will be a game changer. So if we can succeed in getting states to join with us to actually say that through the Medicaid program, through which more than half of the sickle cell disease population receives its treatment, we can actually make it the curative treatment available. That could change things for everyone. Maybe not yet quite at turning the corner, but getting really, really close. And to each and every one of you who fought to make sure we had the right data, to make sure that we provided more access, to make sure that we really did make the investments to develop and discover those curative treatments. Thank you very much. I hope you can say HHS has, over these last few years, been a good partner. And to Admiral Levine, to our leadership at NIH, at not just OASH, but HRSA, and all the different entities, CMS, who are making it possible for us to turn possibility into practical treatment. I just say thank you for being there. I am thrilled to be part of this effort, and I hope that you will continue to include me as we move forward. And so, Dr. Levine, I will turn it back over to you. And I will say, Admiral, this is one of those where I think we actually might be able to tell people that we're going to climb this hill and get there real quickly. So with that, I turn it back over to you and all those champions that are on this call, including Congressman Danny Davis, who I understand will join us at the end. Thank you.
Well, thank you so much, Secretary Becerra. And I am truly honored to be here today to express my commitment to continue to meaningfully engage with patients and families with sickle cell disease and to work to improve the lives of individuals living with sickle cell disease. For far too long, the sickle cell community has not received the full attention and full support that it needs and deserves, and we are committed to changing that reality. I am very proud of the sickle cell programs that HHS leads and has led since sickle cell disease first received federal funding in 1972. These initial resources seeded crucial advancements in sickle cell care, and you're going to hear about some of them today. I want to share a few highlights and sickle cell disease achievements from some of our HHS agencies. Last December, the Food and Drug Administration, FDA, approved 2 milestone gene therapies for treating individuals with sickle cell disease ages 12 and older. And one of these therapies is the first FDA-approved treatment to utilize CRISPR, a type of novel genome editing technology. And this signals an innovative advancement in the field of gene therapy. In January, the Centers for Medicare and Medicaid Services, or CMS, announced a cell and gene therapy access model, which aims to increase access to advanced treatments for people with Medicaid living with rare and severe diseases, including sickle cell disease. CMS also released a sickle cell disease action plan in September, and they are developing a sickle cell disease toolkit. Last year, the CDC, the Centers for Disease Control and Prevention, expanded their sickle cell data collection program, which now includes 16 states, representing approximately 50% of the sickle cell disease population. As the Secretary mentioned, HRSA, the Health Resources and Service Administration, through their sickle cell disease treatment demonstration program and their newborn screening follow-up program, continues to support comprehensive sickle cell disease care systems, which served 25,000 people with sickle cell disease between 2017 and 2021. And last but not least, the National Institutes of Health, the NIH, one of the world's premier biomedical research agencies, continues to fund and support groundbreaking basic science research, clinical trials, and the Cure Sickle Cell Initiative. 3 of today's panelists worked at or were funded by NIH in the 1970s and 1980s, when there was no clear blueprint for treating people with sickle cell disease. These are our trailblazers, and they paved a way for early progress in sickle cell disease research, advocacy, diagnosis, and treatment. And we are truly grateful for their contribution and know full well that we are standing here today on the shoulders of these giants. I would also like to acknowledge our other 2 panelists who are both individuals living with sickle cell disease and strong community advocates. Thank you, all of you, for taking your time today to share your stories and perspectives. Now, I would like to pass the mic to our facilitator, Dr. Julie Penapinto, Director of the Division of Blood Diseases and Resources at the National Heart, Lung, and Blood Institute at the NIH. She is a pediatric hematologist and sickle cell disease researcher and clinician. So I would like to pass things over to you, Dr. Penapinto. Thank you.
Wonderful. Thank you, Admiral Levine. I'm very excited and honored to facilitate today's panel and further represent the NIH's long legacy of supporting sickle cell disease research. We're going to start today by having each panelist share some personal professional reflections for a few minutes each. I'll introduce each of the panelists one at a time for them to share these reflections. The first panelist is Dr. Clarice Reed. Dr. Reed is a pediatrician who retired from the NIH in the late 1990s after serving 25 years as the longest tenured sickle cell disease administrator in the NHLBI. Her fingerprints are on almost every significant NHLBI and blood sickle cell disease achievement made during the 1970s and 1990s. I had the privilege of holding the position that Dr. Reed retired from over 25 years ago. Dr. Reed, the floor is yours for some brief reflections.
Thank you, Dr. Penapinto. Good evening, everyone. I'm delighted to participate in this forum today and join in celebrating National Minority Health Month. I'm tasked today with sharing with you some of my groundbreaking roles early in the sickle cell disease program, particularly on my background, my career pathway, and reflections of the early days of sickle cell disease. First, my background. I'm a third generation sickle family members grew up in the segregated city of Birmingham, Alabama. I attended my father's alma mater, Talladega College, and I became a third generation college graduate. I went to Meharry in the School of Laboratory Technology, and then my first 2 years of medical school. My last 2 years were at the University of Cincinnati College of Medicine. Graduated in 1959 and became the third African American graduate. I will celebrate 65 years by reunion next month in Cincinnati, Ohio. The last 2 years of my career was to attend the pediatrics training at the Children's Hospital in Cincinnati, followed by opening my private practice, where I did see patients with sickle cell disease. Most of their care, though, was at the Children's Hospital just a block away. In 1975, I had my first job, 72, I had my first job in sickle cell disease when my family moved from Washington, D.C., from Cincinnati to Washington, D.C. My husband accepted a position there for a 2-year appointment. My first job was at the sickle cell program, the service side at Hersmaha, which later became HRSA. I was later appointed deputy director of the sickle cell disease program on the sickle cell service side. And in this role, I had interactions with the program at NIH, interacting with the director there, Dr. Rudolph Jackson, along with representatives from the CDC and the Veterans Administration. When Dr. Rudolph Jackson, the director of the program, decided to resign and go to the intramural program, Dr. Robert Levy, the director of the Heart, Lung, and Blood Institute, asked me to come over from HRSA on a 30-day detail. Now, this is a process whereby one agency lends an employee to another agency for a limited period of time while they search for a new director for the program. The search committee was unable to find a director by the time I was able to return to HRSA when the 30-day detail was up. My boss at HRSA wanted me to come back, and I wanted to return. Dr. Levy was very convincing in asking me to stay on to be the national coordinator as well as the chief of the sickle cell disease branch. I was more influenced to stay by the great staff of the sickle cell disease branch, I must dispel the myth that I came to the NIH and had a magic wand that I raised and all the programs became effective with a showering of dollars as well as programs. That was not true. I had a magic team of government workers, social workers, clinicians, all working together collaboratively to move the program forward. That was an excellent experience. The collective experience of expertise and experience of the investigators who were willing to join in the program was actually phenomenal. There were workshops, think tanks, advisors from the intramural program, advisors from the outside hematology, all coming together to help the program become a success. We had several visions of our program. One was to attract leading scientists to work in the field of sickle cell disease. Secondly, to promote and support the best science and to grow the program. These are very, I would think, ambitious goals, and we had some successes and some non-successes. It was a time of great innovation and productivity by the sickle cell disease program. There was always another hill to climb. There was always another project to do. And we kept running down the rabbit hole looking for another holy grail, which never happened. We were very fortunate to have Congressman Lou Stokes as our ace in the hole, who protected sickle cell dollars, particularly for the cooperative study of sickle cell disease, one of the most impactful projects that we had during the early days of sickle cell disease. I was fortunate to have a seat at the front row seated while this most productive years of the sickle cell disease program. For my last 4 years, I served as the division director and expanded my responsibility somewhat to other programs, including the sickle cell disease program, moving to 5 other national program areas. This was also a very enjoyable time and exciting work done during those years. It was an opportunity, again, for me to learn and grow. I was very fortunate to have this experience and will give thanks to all the many people who worked along with me to make this success happen. Thank you very much.
Thank you, Dr. Reed. That's such an incredible journey, and I'm glad you were ambitious to help pave the way for what has followed. So thank you. Our next panelist is Dr. Cage Johnson, who's Emeritus Professor of Medicine at the Keck School of Medicine at the University of Southern California in Los Angeles. Dr. Johnson started his sickle cell disease career in 1972 and is particularly well known for his work in the hematology workforce diversity and adult care models. Over to you, Dr. Johnson, to share some of your reflections.
I'm sorry.
There you go. We've got you now.
My internet service has been unstable, and the program keeps closing and reopening. Where do I start? I was a youngster, an adolescent. I used to have strep throat all the time. And I had a pediatrician who was the very epitome of what a practitioner should be. And he would come to my home. In those days, they made house calls, and he would give me a shot of penicillin. But as soon as he walked,
I think we lost you, Dr. Johnson. So I think while we wait for Dr. Johnson to come back, I may go on to introduce our next panelist, and I'll look for Dr. Johnson to come back. So Dr. Jim Ekman, who is our Emeritus Professor of Hematology and Medical Oncology at the Emory University School of Medicine in Atlanta. Dr. Ekman started his sickle cell disease career in 1975 and is known for his work in acute pain management, newborn screening, and establishing the world's first 24-hour sickle cell disease comprehensive care center in 1984. Dr. Ekman, please give us some of your reflections. And I'll come back to you, Dr. Johnson.
Okay.
Thank you. Oops. Dr. Johnson, go ahead.
Yeah, because you never know when I'll go out again. So when I finished medical school, I went for internship and first-year residency at the University of Cincinnati, where I met my wife, who was actually one of Dr. Reed's patients when she was a child. So after finishing residency, I was around in 1972, and I had applied for the oncology fellowship, but I wasn't taken, and they took a guy that I had no confidence and no respect for as a physician. So then I decided, okay, I'll go out in the community and practice. Somebody dropped out of the hematology fellowship program like 3 days before, and the two junior faculty came to me and said, would I take the position? And I have a lot of respect for those two physicians, and so I decided to accept that position as a hematology fellow. So I had, again, all kinds of serendipitous things happened in my career. So in 1972, we had Darlene Powers, a pediatric hematologist, and L. Julian Haywood, a cardiologist, got the comprehensive sickle cell grant. And that December, they asked me if I would be willing to look after some of the adult patients. So that's how I got into sickle cell disease, really by accident. At that time, there was little interest in sickle cell disease, I think, from the adult standpoint. I'm an internist, not a pediatrician. There's little interest because there was so little to do for such patients other than supportive care. Subsequently, I became a professor. Had no idea I would ever reach that stage. So things that happened to me, doors opened unexpectedly, offering opportunities that I was able to take advantage of, and that led to a very successful career taking care of patients with sickle cell disease, reporting on some of their complications and how to best manage them.
Wonderful, Dr. Johnson, thank you. I think we're all very fortunate that you had that serendipity. So thank you for all that you've done and contributed to the field. Dr. Ekman.
Thank you. So I've began my interest in sickle cell disease in Minnesota, which everybody thinks is kind of unusual. I was at the University of Minnesota in the Twin Cities, and I took care of all of the adults with sickle cell, all 5 of them. And this exposure really piqued my interest in both the clinical and research aspects of sickle cell disease. I was taking care of these patients so that my mentor, Dr. John Eaton, could get blood samples to do his research on the membrane effects of sickle cell disease. And I really found that this was a very challenging and interesting disease. In 1978, I had the opportunity to move to Emory University School of Medicine in Atlanta, where I started the sickle cell program at Grady Memorial Hospital. I developed that program, and I spent my career there in direct patient care, basic research, clinical research, translational research, psychosocial research. I was sort of a Renaissance person, sort of dabbling here and there. I retired in 2013, and I'm now working to improve the care of individuals who are detected by newborn screening. Our programs are established, but we still have rooms for improving the care we provide after the children are detected. I'm trying to facilitate transitioning for our individuals who are moving from pediatric to adult-centered care. And to do this, we're really having to develop the knowledge base for our providers who are providing care to our adults that live in more rural areas, smaller communities, because there are really not providers out there that are knowledgeable. And I'm working to try and find mechanisms for improving their understanding of the disease and their management of the patients. I really can highlight 2 major accomplishments in my career. I think the first was early on, we decided that newborn screening was very important, that we needed to detect the children and keep them alive until we can develop treatments and cures later in life. And so one of the things that I'm very proud of is that I helped 15 states get their newborn screening programs up and running for sickle cell disease after the Gaston penicillin prophylaxis paper and the NIH consensus conference. The second major thing that we accomplished was to develop a 24/7 emergency clinic for adults and a comprehensive birth to death health maintenance clinic for adults and children with sickle cell disease. And this program really improved care locally. It developed guidelines to improve care everywhere. We developed newsletters and a website to share the information that we were getting directly with the community. And we were able to support basic translational and psychosocial research in our center. So sickle cell disease is still very challenging. Every time I saw a patient, I learned something new throughout my whole career. And it's been a very satisfying career path to really help this underserved population do better with a very terrible disease. Thank you.
Great. Thank you, Dr. Ekman, and thank you for all of that work. And all the work that you continue to do. So congratulations on that. Our fourth panelist is Dr. Donnell Ivey, who's a physician, advocate, and an individual living with sickle cell disease. He currently is the health education coordinator at the Association of Black Cardiologists and also serves as the vice chief medical officer at the Sickle Cell Disease Association of America. Dr. Ivey.
Thank you, Dr. Pinapinto, for giving me this opportunity. My name is Donnell Ivey. As it was mentioned, I am an individual that lives with sickle cell disease, hemoglobin SS. Now, I want to highlight that I was born in 1971, so it was right around the time that these trailblazers are mentioning when they got started in their career. Sickle cell disease, growing up with sickle cell disease was very difficult. I would often have crises. Many of the crises when I was a young child would put me in the hospital for weeks to months. And so you can just imagine the consequence that would have on my education. When I was about age 10, I went to live with my grandmother. I continued to have significant crises, but because of that circumstance, she didn't really take me to the hospital. And there was a local doctor that treated me that had limited knowledge about sickle cell disease. But I was fortunate enough to, after graduating from high school, go to North Carolina State University, where I was able to complete my undergraduate degree in zoology and microbiology. While I was getting my undergraduate degree at NC State University, I did have a significant crisis due to acute chest syndrome. And I was hospitalized in the Raleigh area, but I was transferred because of the severeness of my condition to UNC Chapel Hill Hospital in Chapel Hill. At that time, I was fortunate enough to meet Dr. Gene Oringer, who was working in sickle cell disease at the time, and he convinced me to start hydroxyurea. Fortunately for me, hydroxyurea was a game changer. I went from having 3 to 4 crises a year to not having any crises at all due to hydroxyurea. It allowed me to complete my education at North Carolina State University and go on to medical school at East Carolina University. I experienced on hydroxyurea only 1 crisis during my education at East Carolina University, was able to complete medical school and go on to my residency in Savannah, Georgia. It was during my residency in Savannah, Georgia, that what I observed was that although we had hydroxyurea, although as Dr. Ekman and Dr. Johnson and Dr. Reed had mentioned, there had been improvements in sickle cell disease treatment and care, individuals weren't aware, or they weren't taking, or they weren't advantage of the treatments that were available. There were a limited number of individuals that I treated in my residency that were even aware of hydroxyurea. So what I observed was that there was a significant barrier in getting the information out to the patient community about the advancements in sickle cell disease. You know, we can have a cure, but if nobody can get access to it, then what good is that cure to the population? So it was during my residency that I decided to go back and get my master's in public health from UNC Chapel Hill. And after receiving my master's in public health, I was able to get a job at the National Heart, Lung, and Blood Institute working on the sickle cell disease guidelines. We were able to complete and release the sickle cell disease treatment guidelines in 2014 from NHLBI. But just prior to their release, I did take a job at HRSA, Health Resources and Services Administration, working on the sickle cell disease treatment demonstration program and the sickle cell disease newborn screening program. At HRSA, with the sickle cell disease treatment demonstration program, we really wanted to find ways to improve the number of providers that are available to the sickle cell population. So we used the sickle cell disease treatment demonstration program to work with sickle cell centers and try to develop a network that would create more providers that can treat sickle cell disease. With the sickle cell disease newborn screening program, which I also saw at HRSA, we looked at strategies to engage community-based organizations and use community health workers to really outreach to the sickle cell population. I have to admit that I'm here because of the giants that are on the screen, Dr. Reed, Dr. Johnson, and Dr. Ekman. It is through the work that they did with newborn screening, with penicillin prophylaxis as a therapy, with hydroxyurea, which changed my life tremendously, that we were able to even have the sickle cell disease guidelines of 2014. but progress can still be made. And so I look forward to continuing the work to figure out how we get more individuals with sickle cell disease access to the care that can not only prolong their lives, but also make their lives more meaningful. Thank you.
Wonderful. Thank you, Dr. Ivy. You wear lots of different hats and really appreciate your perspective, both professionally and as an individual living with sickle cell disease, and touching on those important things regarding access and the impact of disease-modifying therapy, but more importantly, also education and knowledge of all of those treatments, which are so important for the individuals. So our final panelist I'll introduce today is Ms. Jennifer Fields. Ms. Fields is the president of the Hills Tandem, a strategy consulting firm that she founded in 2014 in North Carolina. This consulting firm supports diverse clients, including sickle cell disease advocacy organizations nationwide. Ms. Fields is an individual living with sickle cell disease and an active community champion and advocate. Ms. Fields.
Thank you, Dr. Panapinto. I wanted to just quickly highlight that I started the company for two reasons. I wanted to build a family legacy outside of the stigma and limitations that I experienced from my interactions in the traditional workforce, while also trying to manage a rare disease like sickle cell. I also saw a huge gap to build community, to build a company that could impact community and families across various industries. So that is where we stand. I'm very blessed to be in a position that I'm in while living with this disease. My past till now has held many challenges, but strong faith, family, work system, colleague system, as well as my strong pediatrics team at ECU, East Carolina University, with Dr. Charles Dashner and some of those other individuals there really helped me to transition with strong educational backgrounds on sickle cell disease and how to manage it, as well as transitioning me to adult care. That has been critical for my success. I would say I'm proud of some of the work that's been accomplished across the country with some of the partners. You've already heard some of the highlights that are
screen scale. Right now, he is just a witness, but if he wants to talk, you have to slide it back over to the left.
Sorry about that, Jennifer.
It's okay. I'm proud of the work that we've been able to accomplish with the partners across the industries in sickle cell disease care and beyond. I started as an educator about 20 years ago in the community, ventured into other public health arenas, then re-enter the space with SCDAA in 2014 to help launch the newborn screening program on this side of the community with SCDAA. Finally, in 2016, we've done a little bit of a shift to work with some of the partners, some other CBOs across the country. Also proud to be a co-architect of the Network in California for Sickle Cell Care model with our trifecta team, the Sickle Cell Disease Foundation, Center for Inherited Blood Disorders, and THT. But we look forward to just sharing as much as we can to continue building the success. We couldn't have been here without our trailblazers. So thank you to everybody who supported this journey for us.
Thank you so much, Jennifer, and thanks for your voice for the community and for all that you do to connect and support the sickle cell disease community. It takes a lot of collective wisdom and diverse perspectives to move the field forward, and I appreciate everyone's input. So we're gonna now pivot to our main event, Care Across the Lifespan. For just a few housekeeping items, the panel will have a discussion for 15 to 20 minutes, and if time allows, we will entertain some questions and answers from our sickle cell disease partners who are on Zoom. You're encouraged to put your question in the Q&A box. If possible, please include your name and state, and if you have an organization, please also list that. We will try to get to and answer as many questions as we can. So our first focus for Care Across the Lifespan, it will be pediatric and transitional care, and I'm going to pose a question to Dr. Reed. So Dr. Reed, can you please tell us a little bit more about the early advances in sickle cell disease that have contributed to a now near 100% survival rate of children living with sickle cell disease in the U.S.? Dr. Reed.
Thank you. Well, I guess the first one will be what's been discussed here so much on newborn screening. Why is newborn screening important? First of all, the deaths in infants and children with sickle cell disease primarily was due to infections. About 40 to 60% of those were pneumococcal infections. So it was postulated that treating sickle cell newborn screening patients identified with sickle cell treated with penicillin would reduce the deaths from sickle cell disease. In 1970, the mid-70s, Howard Pearson at Yale described the success of screening newborns with cord blood. Even though he had made this observation, the pediatric community was reluctant to add that to the protocol of infant screening for other metabolic disease and genetic diseases. It was not until they had the penicillin study to show that we could do something if we diagnosed them with sickle cell disease. That was a landmark result headed by Dr. Gaston from Cincinnati, who was a deputy director of sickle cell disease. She had postulated at the University of Cincinnati before coming to the NIH that this was possible, but we had to do proof of concept that this was possible, and penicillin given at age 3 months to 5 years of age was very successful. There was also a study that followed the penicillin PROPS 1 study, PROPS 2, that showed that individuals with sickle cell disease, the children, that penicillin could be safely stopped by 5 years of age. These findings led to a significant decrease in deaths of infants with sickle cell disease. And though it has not been mandated, it's now not just the best practices. This is the standard of care for all children with sickle cell disease to be diagnosed. Diagnosis is important because it gets children right into early entry into the healthcare system. It has also been shown that just getting into the healthcare system by itself, providing early care and treatment, knowing that you have a baby with sickle cell disease, is very important. I think the challenge after that was to make sure that parents and families knew that kids were diagnosed. And the HRSA program was very good in developing follow-up of the sickle cell disease programs. And I hear today they'll continue to do so. Thank you.
Thank you, Dr. Reed. So Ms. Fields, as we hear about these advances and understand better children are living into adulthood and need transition support for their health care, can you talk a little bit about community-based advocacy organizations and the importance of those to help ensure families are connected to specialists and also have access to the education and mentorship and other resources they might need?
Sure, yes. CBOs are short for community-based organizations. They're critical, they're crucial. They bridge a gap between the families affected by sickle cell disease, that includes the individual, and they really just serve to support the basic needs of everyday life of any person, right? But especially with one with managing and living with sickle cell disease. For the sake of this conversation, I kind of like to think of a patient as, or a person as a pie. The clinical side is one slice of the pie. Everything else is the other slice in the daily lives of a person. So CBOs support a major portion of that other side of life. The clinical side is a slice, and the everything else, to me, sort of in some kind of way can fall under the support of a CBO, depending on their relationships and partnerships. As you said, they play a critical role in connecting families with healthcare providers, navigating healthcare systems, access to resources, education, knowledge about clinical trials that are coming out, and the awareness of them, advocating for patient rights and for better healthcare policies. I mean, there's a robust, really, collection of things that we can say the CBOs can do. However, I do want to highlight that it's critical to note that I don't think that they have fully realized their impact due to, or their abilities due to severe underfunding and the availability of these organizations to receive the funding they need to really be those hands and extensions to the patients in the community, the families in the community, individuals in communities. So if we can, continue to progress and make a shift to support that, I think we'll continue to grow and support our patients into living, or individuals into living their lives at an even higher age, 60s, 70s plus, 80s plus. But I think they're critical in just bridging the gap for everything that's needed.
Great, wonderful. So we may come back to some of the transition, but I'm aware of the time. So I want to move now and pivot to care in the emergency department, which is our second focused area, understanding that acute care utilization and emergency department care for individuals living with sickle cell disease is quite common. So Dr. Ekman, can you tell us a little bit more about how you manage this early on for your patients and the model of care that you established?
Sure, I'd be happy to. So, this is the most important problem for individuals living with sickle cell disease and their caregivers. Emergency care for pain crisis is a major unmet challenge in the individuals with this disease. It really impacts on the individuals, their families, their caregivers, And we're making significant progress, but there's still lots of work to do. And it's a real challenging area to make progress. In the first 5 years I was at Grady, I really could not make any impact on practices in the emergency clinic. And this was a great frustration to me and the patients. And I really learned the power of advocacy because our patients got so upset that they actually demanded that we start a separate emergency room for taking care of the individuals with sickle cell disease. They were successful in convincing us and our administrators that we should do that. And they also went to the legislature and got initial funding to help us meet some of the uncovered costs that would be incurred. This really allowed us to spend a couple of years developing a plan and implementing it to have a 24/7 emergency care clinic, which we established back in the middle 80s. This was a very important program for my education. We really learned what a pain crisis was really like. And we had the opportunity to see patients when they were in pain and when they were well. And so we've quickly learned what was the patient's personality and what was the pain personality when they were in trouble. And this really, I think, improved our understanding on how to manage the patients. We also had the ability to develop care protocols that we tested in our clinic and then disseminated using primarily the internet. We developed standards like getting the first pain shot to the patient within 20 minutes of hitting the door. We're developing individual care plans for patients, protocols for the general patient who we hadn't gotten to know yet. We started protocols to better utilize pain medications to manage the pain, protocols to recognize complications earlier because sometimes patients would present with pain, but they really had more serious problems like acute chest infection or other complications. And so it really became a great model for caring for the individuals. There were many other benefits. Now, many programs have actually taken this model and they've modified it. We had a very large patient population, so we could sustain the emergency clinic, but most programs now are developing day centers or infusion centers that provide the same kind of services over a finite period of time during the day and on weekends. And so this is in some centers moving the care, pain care out of the emergency room, which is the solution that I really used back in the 80s. But I think a more important thing has happened. The emergency community, the hematology community is really starting to listen more to the patients about pain crisis and their demands to improve the care that they receive in the emergency room. And I think one of the more important things that's happening is that the emergency medicine community and the sickle cell community are now starting to talk to each other. We were polarized. We really didn't collaborate. We talked at each other and we didn't listen to each other and hear each other. But now there are really collaborations developing in care coordination, education, quality improvement, and research, where partnerships between the emergency medicine community and other involved medical specialties are collaborating. And I think one of the really important new initiatives that has been undertaken is the development of the Emergency Department Sickle Cell Care Coalition, or the EDC3. And this is an incredibly positive effort put forth by the American College of Emergency Medicine, many other emergency medicine organizations, hematology organizations, nursing and professional organizations, the CDC, Heart, Lung, and Blood Institute, HRSA Joint Commission, and SCDAA. And I think these efforts are surely going to lead to rapid improvements in emergency care nationwide. There's a lot to do. There are many unmet needs, but I think we're making significant progress, and we're talking to each other and developing plans to improve things in the future. Thank you.
Yeah, what a nice model that you helped start and now has really contributed to what you described, which is the partnerships that have grown from that. So, Dr. Ivy, let me ask you if there's anything you want to add from your perspective on the emergency department.
Yes, it was just highlighted by Dr. Ekman. We're making a lot of progress. Dr. Ekman and other sickle hematologists had led the way in developing pain protocols. I know when we released the NHLBI guidelines, we were looking at treatment protocols for acute pain in the emergency room and other acute settings. But I think it's really going to take, as Dr. Ekman was laying out, partnerships. There isn't one group that can do this alone. We have to figure out how we move together, including all parts of not just the clinical setting, not just the hematologist in the emergency room, but also, as it was said by Ms. Fields, the community-based organizations and using community health workers and community health advocates that understand the environment that the patients live in and what the best strategy would be for them in managing acute episodes. As Dr. Ekman said, you know, it's wonderful that Emory, which sees a lot of sickle cell patients, were able to establish that sickle cell day hospital and the sickle cell center that could really improve treatment. But a lot of sickle cell patients don't live like close enough to an Emory to benefit directly. So we do have to look at what are those strategies in rural hospitals and other settings where the ED staff may not be as well suited to take care of individuals with sickle cell disease. How do we link those smaller hospitals, those smaller centers, to the larger centers like Dr. Ekman's centers so that they can get the knowledge and the expertise in managing sickle cell down into those rural areas? So I do think that working not only with the with the ED docs and the hematologists, but finding ways to create networks, create broadening out so that all individuals can benefit from the knowledge that Dr. Ekman's team did early on in sickle cell management.
Thanks, Dr. Ivy. So, Dr. Johnson, what are your thoughts on the comprehensive models of care for adults living with sickle cell disease? So not just in the emergency department and during transition, but throughout adulthood. So I may circle back to Dr. Johnson if we get him back. In the mean, oh, there you are. All right, so moving on, I think, to quality of life. So this is the last focus area. Sorry, Dr. Johnson, we're unable to hear you. We hear you just very briefly every now and then. So
I wanted to say something.
All right, so our last
I'm
focus
really
area.
Sorry, but something wrong with my internet provider. They keep going out. But the cooperative study in the 70s and 80s defined better what sickle cell disease was, as opposed to what we before, which was the individual case reports that now physicians could see the whole spectrum of sickle cell disease, including those who had mild to moderate disease, but also that study defined some of the complications for which we could then develop therapies such as ACE inhibitors for proteinuria, transcranial Doppler for prevention of stroke and initiation of transfusion therapy. All of these have made significant advances, and I could list, pulmonary hypertension recognition and management, bunch of things that now can be done. So that is attracting more physicians into the field and addressing what is, to me, one of the most important needs for this patient community, and that is adult providers. And there are a number of initiatives that are taking place to develop the adult providers. The American Society of Hematology has developed an elective rotation to the 4 significant Duke, Johns Hopkins, University of Pittsburgh, and NHLBI to support an adult physician to come and learn about sickle cell disease and then to take that information back to the community. Pfizer has just opened an RFP for an adult fellowship in sickle cell disease as well. So this is where we have to make the next improvement, advancing the care for patients with sickle cell disease by providing expertise to provide in the adult field. And I think and hopefully others will second this, that this is one of the greatest needs at the present time. So the reason I told you I wanted to be like my pediatrician. So I have 5 grandchildren. The number 3 is a young lady who's a freshman at Emory now, and she wants to be a doctor. So I asked her, why do you want to be a doctor? And she said, I want to be just like you, Papa. That's what they call me. And that was, to me, the compliment that ever could have been done, that someone would recognize.
Well, thank you, Dr. Johnson. I would echo that, having grown up in the shadows of all of the trailblazers on the call, but certainly remembering Dr. Johnson and the work he did as I was beginning my training. So I'm going to circle back to... Yes.
Can I add one thing going back to management and care? Yeah. I must make the statement that the comprehensive sickle cell centers had a lot to do with the change in care for sickle cell disease patients. Care that had been fragmented and impersonal became care that was comprehensive and detailed, using many aspects of social workers, nurses, all coming together to provide a comprehensive approach to sickle cell disease. I remember an article from Dr. David Nathan printed in the division report that the sickle cell disease centers did more in completing and changing the course of care than anything else, the quality of life and longevity of sickle cell disease patients. So we must give some credit to the sickle cell centers that were part of the program, at least for 15 plus years.
Yes, thank you, Dr. Reed, for highlighting that. And so along those lines, I'm going to end with Ms. Fields and Dr. Ivy, if they want to share with us, because certainly as we have these therapies, and Dr. Ivy illustrated one disease-modifying therapy that was very effective for him, talking about quality of life and how from your perspective, what does that mean to you as far as what quality of life issues matter most to you, especially as we now have more disease-modifying therapies available to individuals living with the disease?
Sure. So for me, it's very simple. It's going to be broad, but being able to live a life similar to everyone else, or people who don't live with this disease. I realize there are other diseases that have to be managed, across, just across the world. But to know that the healthcare system works for us consistently, to know that I can build a legacy, and not have to be, turned down for life insurance, just like everyone else, to know that I can get healthcare just like everyone else, and that my copays and my, they won't be more expensive than anyone else's, right? Because of a pre-existing condition, to be able to work, travel, just to be able to live life freely, I think is really a quality of life for me without many limitations. So I think that it's possible. I'm really hopeful that it's possible. I think that all the initiatives that have gone forth, including One of the acts that went out, the Sickle Cell Disease Treatment Act of 2022, which encompassed the comprehensive care model, I think that could really continue to help build the quality of life that everyone needs with this disease. And I think I speak for many people when we say that these are the simple things that we want in life, right? So,
thank you, Ms. Fields. Dr. Ivy.
Yeah, and I'll try to be brief. I mean, echoing what Dr. Ms. Fields said, the quality of life is being able to live the life that you want to, free from the sequelae, but being able to just then live that life. As Ms. Fields said earlier, the clinical part of sickle cell disease is just a small part of a person's life. I want to be able to continue working, continue contributing, own a house, have a family, and do all those other things that individuals without the disease do without having to think about my disease constantly. And I would imagine that most individuals with sickle cell disease see it as they want to be able to live their lives free of the stress of living with sickle cell disease, even though they have this disease. So I think looking at strategies to allow them to get comprehensive care, to allow them to focus on things other than sickle cell disease. And we need to look at that transition. Every individual goes through transition, but how do we make it easier on the sickle cell patient so that transition isn't just about their sickle cell disease, it's also about reaching those other milestones in life. So I would echo what everyone said in that, really we just want to be able to live a life that's worth living.
Thank you, Dr. Ivy. And I know I just had one question that I will briefly touch on. I do believe Dr. Johnson answered it, and it was with regard to, is there work being done to advocate for training and educating health professionals? So I think, Dr. Johnson, you touched on that. So I think we are at our closing remarks. So I want to thank the panelists and the attendees for your participation, and I want to turn the mic over to Representative Danny Davis for closing remarks for us. Representative Davis.
Well, thank you very much. And I want to thank all of those who have been engaged, been involved, and been associated with this effort, some for probably as many as 50 years or so, which is when I first came into contact with it and actually worked with Dr. Maurice Rabb at the University of Illinois in a sickle cell grant that he had gotten. And of course, Dr. Bowman, James Bowman, was over at the University of Chicago, and he also had gotten a grant that had become available after President Nixon had signed the sickle cell law into legal activity that could generate some resources and some monies. Of course, all of the movement from back then to where we are now has been delightful to see, although it's been slow, it's been tedious, but individuals like the panelists, and I also just want to give a shout out to Dr. Michael Burgess, who co-chairs the Sickle Cell Caucus in the House of Representatives, and Representative Barbara Lee, who has been seriously and actively engaged and involved. But all of this activity has brought us up to the point where we have gene therapies that have been approved, which gives a great deal of hope and possibility to all of us who look and who see and who believe. And some patients also take the position that for all practical purposes, they have been cured. I've listened to patients who have testified, who went through the clinical trials, and they raise their hand and say for the first time in their lives, they have experienced living with no pain. So I think that gives all of us the notion and the possibility that if we continue these efforts, continue this work, and I want to really thank the Secretary of Health and Human Services for his personal engagement, involvement, and commitment. So we leave closing with a great deal of optimism that we have not gotten where we need to be, but we're well on our way. We need to continue the education, the advocacy, and appropriate more resources to continue with the research and the treatment methods that have been developed. So thank you all. I am excited. I enjoyed all of the panelists' remarks, and I do believe that in a relatively short period of time, we will be able to make these therapies available to more sickle cell patients so that they too can experience that quality of life that we're talking about. So thank you all so very much, and have a wonderful, wonderful evening.
Produced by the U.S. Department of Health and Human Services.